I'm here in Mexico City for the Latin Cardiovascular Symposium in collaboration with the American College of Cardiology. We've had wonderful 3 days of meetings, successful symposium, lots of data sharing, best practices, lots of knowledge exchanged, and we will do this again next year. Mexico and the United States are pretty similar. We reviewed data yesterday in one of my lectures and a discussion panel that data from large registries, the data that I showed yesterday was from the Interheart study, which sampled men and women after a first heart attack and compared them in terms of their health and their risk factors. And we're pretty similar. And that was actually true pretty much around the world. We, as human beings, are a lot more alike than we're different. It turns out that women, before they get their heart disease, are actually a little less at risk, although when we count up the deaths from cardiovascular disease each year in the United States, in Mexico, it's about 50-50 women and men. So it's probably not really right to say that a man or a woman is more or less at risk for heart disease anymore. I think it's equal opportunity. Once a woman gets heart disease, she does not do as well as a man. And some of that has to do with women are not as easily recognized and more frequently are not appropriately treated. They're not given some of the life-saving therapies that we know work. And that's one of our quality initiatives, is to ensure that the physicians in the hospitals throughout the world are using guidelines, because guidelines then overrides things like implicit bias. And then the second thing is women and men hearts are a little different. And so there's knowledge gaps that we need to continue to investigate to understand how we can improve women's lives. Men's heart disease seems to be pretty straightforward. The research that we've done in the last 50 years works quite well in men. It doesn't always work exactly the same for women. So we're working on that. That's a microvascular study. That's a Takotsubo cardiomyopathy study. That's a heart failure with preserved ejection fraction studies. These are all research that we can do nationally in the U.S., but we can do in Latin America, Mexico as well. A couple of phenomenons contribute to why women are less likely to be treated. Number one is they don't look like men, and a lot of our diagnostics are set to a male standard. So, for example, diagnosing a heart attack, you have to have a certain rise in a blood enzyme level called a troponin. Women's hearts are smaller than men on average, and so 1 out of 5 heart attacks will not be picked up by the current troponin standard because it's a male pattern standard. I mean, that's just an example of something also that would be fairly easy to fix. We could just recognize that women's hearts on average are smaller, and we could have a threshold for men, and we could have a threshold for women. So that's one of the quality initiatives that we'll be working on. Another contributor is that women are a little different, and that some of the presentations are different enough that it requires different therapy. So this microvascular angina, or what we call now coronary microvascular dysfunction, you need special techniques to detect it, either invasive flow reserve or a cardiac MRI or a PET scan. And so this is another education initiative. And we know how to treat angina, so it's also getting over some of these implicit bias that just because the arteries aren't plugged up doesn't mean that you shouldn't treat the angina in a patient that's often a woman. Women, on average, continue to have better longevity than men, but that gap is narrowing, and not because women are dying more often, but mostly because men are living longer. And that tells that story that we're doing a very good job of therapies that were developed in men, for men, and by men. And wouldn't we want to anticipate or even expect that women should also be benefiting from the research and the discovery and then the implementation of therapies that extend life? And cardiovascular disease is the leading killer of women and men. So a lot of this gap is due to cardiovascular disease. And it's an equity thing. I mean, women deserve this. We're valuable too. And it's also an issue of how does society want to spend its money? And do we want to spend our money on a lot of old, frail people that need nursing home care? Men are less and less likely to need that. And because we're doing things that really preserve their cognitive function, their ability to get around, their cardiovascular system is necessary to walk and do your activities of daily living. So we need to do the same for women because it's the right thing to do, but it's probably also economically the right thing to do. So symptoms of heart disease in women are both typical, which is a male pattern symptom. So that would be pressure, squeezing in the chest that is brought on with some type of exertion and is relieved with either rest or one of those little nitroglycerin tablets. That's typical symptoms. That's about 70% of men. It's about only 50% of women. Men and women, but dominantly women can also have atypical symptoms, which broadly categorized as anything above the waist. It could be shortness of breath, it could be not pressure, it could be a shoulder ache, it could be indigestion, it could be overwhelming fatigue. So women, half of women have atypical symptoms. So, and again, 25 to 30% of men have atypical symptoms. So the strong public health advisement is that if you're having a symptom above the waist that is unusual for you, is not related to something that you've already, figured out with your healthcare provider, call your doctor, discuss it with someone, don't ignore it. One of the things that we're realizing as our sociologists and our psychologists do research is that certainly within healthcare, where physicians are trained to put the patient's interests ahead of their own and to, the Hippocratic oath, which is to always do right by your patient. And this is a very resounding principle. I think you will find it in essentially all physicians. So it's hard to imagine then that physicians dislike women or even hate women, which is what misogyny is defined as. And what we've demonstrated in our research as well as others is that physicians and women have a lot of implicit bias that is related to gender. And again, remember, gender is how we see women and men, and there are gendered roles, and there are gendered ways of saying things, there are gendered ways of moving about in society. What happens when women and men go to the doctor and say that they're having chest pain, again, because of this implicit bias and because a lot of physician training until recently was that women were much less likely to get heart disease, the physicians immediately discount implicit bias, discount the symptoms in a woman. And therefore, then you see the data where men are more likely to be tested and women are more likely to be dismissed. So it's pretty clear it's an implicit bias. And what's good about that is that we can address implicit bias. There are good research studies that you have to set into place, programs and protocols. You have to first acknowledge that it's happening. And we publish these things every 5 to 10 years. So I think physicians are increasingly acknowledging that it does happen. And then programs in healthcare would be guidelines. And we've demonstrated that improving guidelines definitely has made a difference in women's lives. Why do a majority of women not get any kind of risk assessment? Our research suggests that women don't get risk assessments, again, probably because of this implicit bias that physicians rank order breast health and weight management above cardiovascular risk assessment. That's a problem. It's a big problem for women because it's a preventive opportunity that is lost. In our survey, however, we didn't survey men. So we don't know. It could be that 60% of men are also not getting risk assessments, which could be true because busy physicians, unfortunately, are paying attention sometimes to things that maybe aren't the most important. You should be getting your blood pressure checked once you turn adult, and that is either 18 or 21, depending on your local environment. And then you should get your cholesterol checked again as an adult, depending on the guidelines, every year or every 3 or every 5 years. People should be screened for diabetes when they get to men and women at the age of 50. So these are all the routine assessments that go into that heart risk check. And so, in fact, there's no magic age. Everybody should be thinking about and getting checked for heart disease risk starting at the age of an adult, 18 or 21. We think that explains the response to physician prioritization of health problems. In our physician group, our primary care physician group, who's doing the majority of this work, rank ordered breast health and weight management above cardiovascular health. So these women are responding in some ways to cues from their physicians, if that's what they talk about in the exam room. And number two, we think, this would be our explanation, it's also an example of the implicit bias of our gendered society, where women are more objectified. This is, again, a well-validated fact. We look at women more. Women look at women more, men look at women more, and women are more judged on their appearance than men. So there's a lot of cues to women to worry about their weight. And knowing that they're going to go to the doctor's office and the doctor's going to prioritize their weight over cardiovascular health makes sense now. We had an excellent meeting. It drew cardiologists from all over Latin America. Of course, a majority were from Mexico because it was held in Mexico City. I think we learned that cardiologists are cardiologists around the world. We're pretty similar people. We're pretty high energy. We are can-do kind of people. Sometimes we are limited because of resources. Sometimes we are limited because of politics. That's certainly true in the U.S. currently. But we get together and we problem solve to do the best for our patients. We had several sessions on women's health. We did not specifically talk about how women were doing in Mexico other than that interheart data that I discussed with you. We talked a lot about initiatives that the United States has done that has been quite successful, and we encouraged our Mexican colleagues to measure look and see how women with heart attacks are doing, have data that is specific to each country, because if you don't measure, you don't know how well you're doing. And these kinds of meetings are often inspirational. We challenge everyone to go home and do a better job. So we'll look forward to future meetings and looking at data that would be country-specific, Mexico included. And there are a number of leaders here that I think will do it. And we'll see, how are women doing in Mexico? Be good to know. So advances in the Barbra Streisand Women's Heart Center at the Cedars Sinai Heart Institute in Los Angeles are manifold. We have lots of research programs ongoing in essentially every aspect of women's heart disease. We translate that quite rapidly into our clinical care, which is our outpatient clinic for diagnostics and treatment, as well as inpatient. We do a fair amount of procedures. We offer holistic integrative care. We do a lot of prevention and rehabilitation. Ms. Streisand is a philanthropist, and whenever she goes on tour, she directs a high percentage of her proceeds to a charity. And she had designated this tour years ago for a women's health cause, and I applied for it. I think women need to do two things if they are asymptomatic, otherwise they're for routine reasons. They need to ask for a heart check, and that's that heart disease risk score. And then number two, for women that are having symptoms, they need to be evaluated. They need to be taken seriously. Just because they're a midlife woman or they otherwise look fine, they're not overweight, they need to be tested. They need to have a diagnostic, at a minimum an EKG and a stress test.